Hello, everyone, and welcome to this afternoon's session with Harold von Bossie. Just a few housekeeping things before we start. There will be time for question and answers at the end of the session, so if you could utilize the chat function to ask your questions, we will be addressing those at the end of the session. Everyone will be muted during this session, and please don't forget to take the survey at the end also. And so, without further ado, I have the pleasure of introducing Harold von Bossie. He has practiced pediatric orthopedic surgery at the Shriner Hospital for Children in Philadelphia since completing his orthopedic residency at the University of Illinois in Chicago and fellowship at Toronto's Hospital for Sick Children in 1999. He met a family of a 2-year-old boy with Prader-Willi syndrome and severe scoliosis. Through that patient, Dr. von Bossie was introduced to the community of specialists caring for children with Prader-Willi syndrome. Much of his efforts have been treating the very young child with PWS and spine deformities. Dr. von Bossie is a member of the Clinical and Scientific Advisory Board of IPSO, the Clinical Advisory Board of PWSA USA, and has enjoyed giving talks on the Orthopedics of Prader-Willi syndrome at PWSA USA, PWANY, FPWR, and PWCF meetings over the years. Thank you.
Thank you very much. Let's see if I can make this all happen here. And hopefully you're now looking at my screen. And I just want to say that, like everybody else, I really missed the in-person conference. For example, having Justice run up and give me a hug, or have Jen Miller grab me to look at a new baby, or having Janice Agrawal do this talk with me, which is one of my favorite things to do. So for those of you who haven't gone to a meeting, there's a lot to look forward to in a couple of years when we can have an in-person meeting again. In the meantime, I'm really honored to be here, even if it means I have a virtual background that's hiding my very cluttered office and that I'm wearing a telemarketer headset. But let's go ahead and get started with Orthopedics of Prader-Willi syndrome. And so I always like starting with a little recap of Prader-Willi syndrome itself. So it's the most common genetic obesity syndrome. It was first described in 1887 when Langdon Down talked about an adolescent girl with the typical type features. But it wasn't until 1956 that Prader, Labhart, and Willi actually published articles on a series of patients that they had. And Labhart, being the middle child, kind of got forgotten in the process here. And then about 25 years later, these authors here were able to figure out that microdeletions of chromosome 15 were the cause for Prader-Willi syndrome. So what is the genetic side of Prader-Willi syndrome? Well, it happens at chromosome 15, and vital information is missing from dad's part of the contribution here. So it's this little area here at chromosome 15. Now, if it's that same area is lacking from mom, this could be something called Angelman syndrome, which is a very different syndrome. And it could be lacking in a few different ways. At the bottom here, we have where you have a deletion, that area is just missing. You can have 2 chromosome 15s from mom and none from dad. It's called uniparental disomy. And the more rare type is just where this area is present on dad's chromosome or dad's contribution, but for some reason, it's just not working. Now, genetic syndromes like this are unlikely to run in families, except for the imprinting type. That one has about a 50% risk of running in a family, of having more than one child with Prader-Willi syndrome. What are the characteristics? Well, as an infant, these children are very hypotonic, very low-toned. They can have hypogonadism, meaning that the sex distinctions, the sex features are small, strabismus, short-statured, small hands and feet, and of course, the obsessive food interest and obesity, and that starts someplace between 1 and 6 years of age. And if those of you who were able to catch Dr. Miller's talk know that happens kind of further on, actually, once they've already started to gaining some weight. Now, the interesting thing about the small hands and feet and the short-staturedness is that the growth hormone has really been blurring that lately. We see a lot less of that. Older children have learning disabilities. They can have behavioral problems. And the big question I always hear is, why doesn't my orthopedist know about Prader-Willi syndrome? How come they're kind of generalizing it with other syndromes that they do know? Well, it's because Prader-Willi syndrome is really quite rare. It's about 1 in 10,000 to 1 in 30,000 births. And if you compare that to other things that we see in orthopedic surgery that are relatively uncommon, But for us, our common cerebral palsy is 1 in 500, spina bifida is 1 in 1,000, hip dysplasia, club feet, 1 in 1,000 or 1 in 2,000. And these things are already seen as pretty rare. So that means that Prader-Willi syndrome is extremely rare. And what unfortunately a lot of people will do is they will tend to generalize their treatment thinking from what they know about other conditions. And that's always a problem that you run into with Prader-Willi syndrome because it doesn't always follow the same rules. So in this talk, we're going to talk about some orthopedic and rehab issues in Prader-Willi syndrome, starting off with developmental delay, going down to joint laxity and flat foot, which is the most common way that we see joint laxity present itself in Prader-Willi syndrome. We'll talk a little bit about low bone strength, and then hip dysplasia, and then finishing off with spine deformities. So to start with developmental delay, we know that these children are very hypotonic at the start. And in fact, prenatally, they're very hypotonic. Parents will often tell us, moms will often tell us that there wasn't as much kicking in the pregnancy of a child with Prader-Willi syndrome as there had been on their previous pregnancies. Oftentimes, the children are born at or post-term, and many times require cesarean sections just because they themselves don't have the ability to kick themselves out. As a newborn, oftentimes they'll have poor sucking abilities. They can have a weak cry. They end up in the neonatal intensive care unit for a period of time to help with the feeding. Infants and toddlers show poor head control and also poor postural control, such as with sitting. They tend to kind of slouch down into a position. And the milestones, by and large, take about twice as long as they do in typical children. So whereas a typical child will be sitting at 6 months of age, children with Prader-Willi syndrome start sitting about a year of age. And walking happens typically at 12 months of age, but in children with Prader-Willi syndrome, the average is about 27 to 29 months of age. So what do we see on physical examination? Well, we see a weak, low-tone child, and the trunk tone has much lower tone than the extremities. Also, again, the hands and feet are small and narrowed. Again, this is something we see less with growth hormone these days. Genitalia have their findings. What is the treatment? Well, it's really therapy, therapy, therapy. We want these children to be as active as possible. We want to work on balance and motor abilities. Early intervention is so important from the very start until school-based therapies can take over. Bracing is very helpful. We want to give them ankle and foot control. If you think of when you're standing, it's kind of like building on a foundation. If your ankles are not giving you the stability that you need, your whole building is going to collapse. So we want to give them stability around the ankles. And if we do that, we're actually also helping to stabilize the knees. So very early on, usually about a year or so, I'll start the kiddos off with what are called ankle foot orthoses or AFOs. And these need to be solid ankle because, again, we're trying to support the ankle. And so they have a good foundation. And if you go to my clinic, you'll hear this mantra all the time. We try to get these kids walking any way possible and then work on points for style. I don't see any benefit of a tough love type thing of, oh, you give them a brace that's got some motion to it because then they're going to learn how to walk with that. We want to get them up walking so that the walking itself becomes rewarding. And once that happens, they're going to be walking a lot more, and that's going to get them stronger and stronger. So this is what an AFO looks like. This is for an older child, not for a 1-year-old, but it's the same kind of idea. It's a brace that is solid at the ankle, has a couple of straps to hold them in place. And so when they're standing in it, it's helping to hold them upright. And we use this until they're walking well, and then we discontinue it. We might continue on with a smaller brace if their foot shape requires further bracing, which is then a perfect prelude now to talk about flat foot deformities in Prader-Willi syndrome. So you see on this girl here that the ankles, especially over on the right there, the ankles are really rolled inwards or the heels are rolled outwards, whichever way you want to look at it. And the picture on the left, you'll also notice that the front of the foot is kind of veering off to the outside on both sides. So flat-footedness happens very often in Prader-Willi syndrome. About 40% of children have that. And that's because they have lax ligaments and also they have decreased strength in the muscles that hold up the arch. So their feet tend to fall into pronation. And that means that they have less strong foot functioning when they're running or when they're walking. And what that causes is poor balance. So oftentimes these children will walk with a wider base, so they'll have their feet further apart from each other when they're walking. They complain about fatigue more because it takes a lot more effort than in the rest of the leg muscles to hold yourself upright. And their posture will also suffer. They'll tend to be a little bit forward rounded in their posture. And they do something called high guard, which is that they hold their arms up because they're worried that they're going to fall and they need to have their arms ready to protect themselves instead of using their hands for useful purposes. So here is a child with not really bad flat feet, but he helps to give us a little bit of an insight into what we need to do for these feet. So you see that both the heels are kind of rolled to the outside, and you can kind of see that the arches there are pretty much touching the ground. And if we just put an arch support, which is what my fingers are doing there, you'll notice that maybe we're holding the arch up, but we're not rolling the heel. And it's that rolling of the heel that's really important. We want to roll that heel underneath the ankle, like what I'm showing here. And that helps balance the rest of the foot. So we use a brace that's going to roll the heel underneath the ankle. And secondarily, we want to push the front of the foot over a little bit. So this particular brace is called a UCBL, which stands for University of California Bioengineering Laboratories. The other brace that's used a lot is something called a SMO, or supramalleolar orthosis. So a little bit of a philosophy difference about why you would use one brace type versus another. I'm more of a fan of a UCBL than an SMO. Those arrows, by the way, are showing how the heel gets rolled back underneath the ankle with this brace. And so here, another couple of pictures showing how you're kind of rolling that ankle underneath the heel. This happens to be a SMO, and you can see that by the fact that it comes above those little ankle bumps that you have on either side of your ankle. This is what I want to avoid, though, when we do any kind of bracing like this, because the front of the foot wants to kind of swing to the outside. So you need to have a brace that prevents that from happening, or else you'll have this wide gapping over here. So I want to have that wall come up on the side of the foot, kind of pushing it back over to the inside, so that we not only roll the heel underneath the ankle, but we also correct the front of the foot alignment with the heel. And you'll see that when they have these braces on, altogether, the whole limb alignment is better. They're not as wide based in their gait. Their heel is underneath their ankle, and they're able to stand with their feet closer together and balance better. I want to move over to osteoporosis, or weakness of bone fragility. So osteoporosis, weak bone, or we also know it as low bone mineral density. When you think of bone, it actually is a structure of proteins, and on that structure of proteins, you hang the calcium, and that's the calcium is what makes the bone strong. So it's almost like having a building where you have the infrastructure of metal girders and such, and then off of that, you have the siding that holds everything together with the concrete. Different studies have shown different rates of bone fragility. So PWSA USA had a survey, been a while ago now, but 9% of respondents said that their loved one was known to have weak bone. But then there was a British study looking at adults where 29% of adults had had a history of a fracture. 29% of adults with Prader-Willi syndrome had a history of a fracture. And one of the points they made is that people with Prader-Willi syndrome have a decreased pain sensitivity, so sometimes took a little while to identify a fracture. And another study done here in Philadelphia, again, going back now a couple of decades, but there 45% of adults had a history of a fracture. Now, bone mineral density is known as having a 20% lower amount of bone mass on what's called a dual energy X-ray absorptiometry, or a DEXA scan. And what we found in Prader-Willi syndrome is that the lower bone mineral density tends to be in the lumbar spine, the pelvis, and the lower extremities and the legs. And we don't see as much of a difference in the head, the upper extremities, or the thoracic spine. So the lumbar spine is your lower back. The thoracic spine is that part of your back where the ribs are. And this is what a DEXA scan looks like. So what's the treatment? Well, treatment certainly is growth hormone. And I would say that in comparison to what I've read in the literature, I've seen relatively few fractures in my children with Prader-Willi syndrome. Maybe once a year or so, I'll hear about somebody who had a fracture. So I think the growth hormone really is helping, as is just the all-around understanding of the importance of nutrition and activity. And supplemental vitamin D and calcium is probably important for all of us, not just our children with Prader-Willi syndrome, but we as adults and typical children in the United States also required that. And having an awareness that this is an issue, so that if a child with Prader-Willi syndrome does take a fall and they're limping afterwards, or they're holding their arm strangely, understand that that could be a fracture, needs to be worked up. And if there's surgery being planned for these children, that the surgeon takes in mind the idea that the bone may not be as strong as what they would typically expect. Now I'm going to move over to hip dysplasia. On the left is a relatively normal hip. On the right is a hip with dysplasia. And the area to look at is right over here at that corner of the socket we call the acetabulum. And you'll notice that on the left, that corner is kind of starting to tilt downwards, whereas on the right, it's kind of still heading up in the air, and that the ball is well covered on the left, whereas on the right, it's not. So on the right is a child with hip dysplasia, or is actually an adult with hip dysplasia with Prader-Willi syndrome. So dysplasia means abnormal development or growth. And what we presume is that the hip was actually normal early on in development. And the reason for that is that the hip is developed out of a solid block of cartilage. And at about 8 weeks of pregnancy or so, you get this cleft that develops in the cartilage that separates the ball of the hip joint from the socket. And so that's probably when it's at its most stable. Now, what happens intrauterally is that most babies kick around a lot, and that helps shape the two sides of the socket, whereas children with Prader-Willi syndrome are not very active intrauterally, and therefore they probably start off with something of an underdeveloped socket. Now, you can have congenital dislocation of the hip, where the child is born with the ball of the socket outside of the socket. Now, there are some other authors who have mentioned this happens fairly commonly. I haven't seen it all that commonly. I only know of 2 children in my practice who were born with hips out of socket. And in fact, both of them were treated before they came to see me. But other centers have reported a higher incidence. So it's something to pay attention to. But again, I don't think it's an extremely high percentage. But the percentage of hip dysplasia of a hip joint that's not well formed in the literature is anywhere between 8 and 30%. So nearly 1 out of 3 patients with Prader-Willi syndrome could have dysplasia of the hip. So what is the prevention? Well, I think it's important to do early screening. And we want to do that when the child starts sitting. I don't do ultrasounds on the babies. I wait until I'm going to get screening x-rays of the spine. And at that time, I also want to see what the hips look like. Otherwise, we want the children to stay as active as possible, because that's what helps develop the hip joint, is having gravity and muscle forces across the socket that helps the socket develop normally. And then we want to continue to screen these hips over time to make sure they're going in the right direction if we've identified a hip that's got a problem. Now, hip arthritis is the big thing that we worry about. So typically when we talk about hip dysplasia, we're not worried about the child, we're worried about the adult, that they don't have a well-developed hip joint and they're going to have pain in the future because they're getting arthritis. There's very little reported on this in terms of Prader-Willi syndrome in the literature, and it's probably because there's too few cases per surgeon. So FPWR actually sponsored a project that we had where we looked at a national database of hospital discharges, something called the HCUP, the Healthcare Cost and Utilization Project. And this is responsible for 7 million annual stays in the United States per year. And there's ways that they can play statistical games with that. So it actually represents about 35 million stays per year. And we looked at an 11-year time span to see all people who were born, all people who underwent a total hip arthroplasty. And then we could compare those that had Prader-Willi syndrome to those that did not. And what we found is that there were 3.1 million total hip arthroplasties when we looked at the weighted data, but there were only 39 of those who had Prader-Willi syndrome. Now, the interesting thing was that nearly 70% of those had their hips replaced before 50 years of age, which is a pretty young age to have that done. Now, how do we put these numbers in context? Well, we think that the incidence of Prader-Willi syndrome at its most rare would be 1 in 30,000. But the incidence of needing a total hip arthroplasty was about 1 in 80,000. So really for me, the message was that the rate of total hip replacement in adults with Prader-Willi syndrome was lower than in the typical population. So even if we're saying that the rate of hip dysplasia is higher in people with Prader-Willi syndrome, their rate of needing a hip replacement because of symptoms in adult was much lower. And that tells me that we are probably not needing to be too concerned about, in general, people with Prader-Willi syndrome having hip dysplasia. But there are still the individual cases. So we look at this child here, where the socket is really not covering over the ball at all on either side. And more importantly, the top of the hip bone here is very, very straight up and down. So that's where what the socket should look like. So what we did is we angled the top of the hip bone so that the ball was facing more into the socket. And then if you look at this a few years later, you're starting to see how the socket is now starting to respond better. It's actually starting to get a better look to it. But what about if we can't treat everybody, or actually a better way of saying that, is this what should happen for all children? Well, here's a 5.5-year-old child that if this child did not have Prader-Willi syndrome, I would be signing them up for surgery very quickly. Because at 5.5 years of age, a typical child is not going to improve the shape of that socket. But here they are at 7 years of age, really starting to look like the sockets are improving. And here at 10 years of age, and I would state that any pediatric orthopedist would look at this and say that those are normal looking hips, that they've really come together very nicely. Well, here's the 13-month-old. Again, these hips are not looking very healthy at this time. This is what the green line is showing where the socket should be at this age. But here they are, just 4 years later, and those are pretty normal looking hips. But so what's the summary on that? Well, the summary is that the hip dysplasia can have serious consequences and we need to screen for it. And if you look at this x-ray that we started off, the one at the right there, that patient's probably going to run into trouble as an adult and may need to have a hip replacement. So that's why we need to screen for those and treat the ones that are not improving on their own. But the best treatment to start off with is activity, so that gravity forces and muscle forces go across that hip joint and help the two surfaces form to each other. I don't like harnesses or braces. This is what's typically done for babies who have hip dysplasia. But if you do that in Prader-Willi syndrome, first of all, they don't move around a whole lot as is, and you put one of these harnesses on them, and that makes them even less mobile. The other thing is that typically babies with Prader-Willi syndrome position themselves in the position that we want to put them in with the harness. So if this is a ball inside a socket, they kind of lie out like this. They're kind of in that splayed open position, which actually puts the ball deep inside the socket, and that's their normal resting position. And that's fine for the hips to be in. So I don't think they need a harness to do that. But then what do? Well, we keep on watching them in a regular interval. And if the improvement of the hip joint stalls out, that's when we should do something surgically. But we should not apply the same rules as we would for typical children. All right, now let's get to the meat of the matter here. Let's talk about spine deformities. So first, a couple of terms. Scoliosis is a side-to-side curve that you see when you're looking at somebody from behind. Kyphosis is the front-to-back curve that we all normally have in our back. But what we have is, when we talk about kyphosis, we're actually talking about an exaggeration of the normal curve, such as you see here. We can also talk about lordosis, which is in the lumbar spine, in the lower back, and that can also be exaggerated, where you have a hyperlordosis. So let's do the numbers. The prevalence of spine deformities in people with Prader-Willi syndrome before they reach the end of growth is between 60 and 70% if you look at the literature. Now, not all those need to have treatment done. This is something of a bimodal curve where about a quarter of the children will have some sort of a presentation of a spine curve before the 4th birthday. And then the second peak happens more at adolescence. So it's kind of this quiescent period between 4 and say 10 years of age. And then we have to get worried again. Now, about 15% of children with Prader-Willi syndrome will need to have spine surgery, and a bigger percentage of that will need to have bracing or something similar done. The complication rates, if we look at the literature, is pretty high for doing spine surgery on children with Prader-Willi syndrome. So it's about 50%. And I think that's getting better as we're getting more aware of it. So what are our guidelines for treatment? Well, in general, curves under 20 or 25 degrees we observe. When they get over 25 degrees in growing children, we want to treat them. We're going to talk about different ways of treating it. What's our endpoint though? And what we're looking for is what the curve is going to look like when the child is done growing, when they hit maturity. So if you have a curve under 40 degrees when your child is mature, 95% of the time, that curve will not progress in adulthood. If it is greater than 50 degrees, 95% of the time, it will progress in adulthood. And between 40 and 50 degrees is something of a gray zone, and those curves need to be followed very carefully. So surgery is usually indicated for curves that go over 40 or 50 degrees. Personally, if I have a curve that's over 50 degrees in a growing child, what I will try to do is continue to brace them until the curve is greater than 50 degrees in the brace, and that will be a reason for me to do surgery. Or if the child is just about skeletally mature, then we can choose a time to do the surgery. One of the big problems with Prader-Willi syndrome, though, is the delay in diagnosis of spine curves. And that's because these children, for whatever reason, are really good at hiding their curves. Some of it has to do with how the spine rotates when you have a curve, and a little bit of a complex thing to talk about over the video. So I'll have to say that for an in-person conversation. But if you look at this 8.5-year-old boy, you say, yeah, there's a little bit of spine asymmetry there. We see he's got these clefts are at a little bit different levels, but nothing that looks too outrageous. But he actually is outrageous. It's just about a 100-degree curve that he was hiding. Or this child here, 18 months old, we see a little cleft here. Maybe she's a little bit more prominent there, but she also has a curve that's about 100 degrees. Or this boy, you probably wouldn't look at him twice if he's running around the swimming pool, but he's got this 30-degree curve, which is not a huge curve, but it's certainly one that you want to know about and start treating to prevent it from becoming a bigger curve. What's a few things that we know about scoliosis and Prader-Willi syndrome? Well, everybody always wants to blame it on obesity, but there doesn't seem to be any difference if we look at body mass index between those children who have curves and those who do not. And in fact, about half of the curves start in children before they get into trouble with obesity. So more likely these curves, especially in the young children, are related to their hypotonia, their low tone. Obesity control is still very important so that we can detect the curves, and also for treatment modalities such as casting or bracing. PWSA USA did a couple of surveys, and the one in 2007 showed a few things. First of all, in terms of gender, it showed that females were a little bit more likely to have a curve, but once girls and boys had curves, they had about equal risk for progression of that curve. In terms of genetics, UPD seemed to have a slightly higher risk for developing scoliosis, but no risk type, no PWS type had a higher risk for progression. And personally, I'm really looking forward to the results from the global registry, because I think that's going to tell us a lot more about what these curves look like or how they progress. So why treat the curves? Well, the first thing we talk about is really the cardiopulmonary compromise. It's not so much that they don't have a nice looking posture or they're going to get back pain from the curve. The thing we really worry about is what's going to happen to the respiratory status. Now, this is a typical problem, or this is a problem that we have in typically developed children, but even more so in children with Prader-Willi syndrome, because as we all know, they have respiratory issues from the start. So what's the problem? Well, if you look at this chest over here, you'll notice that the lung fields are very asymmetric. On this side, the lung field, because here's the diaphragm, so the lung field is very much squished from top to bottom. And on this side, it's kind of squished from side to side. So there's not enough lung that's working normally to get oxygen into the bloodstream. And then what happens is that over time, the heart is working so hard to push blood through these squished lungs that it actually gets tired out, and it develops something called cor pulmonale. And again, if you listen to any of the scientific talks over the past couple of days, there was a very good discussion about that, how you get this overworking of the heart. Now, typically that doesn't happen until the curves are 80 to 90 degrees in size, but even the smaller ones, those over 60 degrees, if you do the right studies, you can find that the lungs are not working as well as you'd like them to be working. So let's talk first a little bit about infantile scoliosis. Here's a little girl, 1.5 years of age, and she's already got a 43 degree curve. Now, one of the important things you just see is that very typical Prader-Willi hypotonic way of sitting. She's kind of slouching down into herself. And that's one of the big themes that we have for these children, is that we don't want them to be up and around before they're ready for it. Now, as all of us as parents, we always get very excited about having the children getting up and sitting and getting up and getting around, and we want to help them sit. In Prader-Willi syndrome, we really don't want to do that, because what they end up doing is they do the slouching type thing, and we think that that kind of kickstarts their curve. So typically what I'll tell parents of the young children, that what I want them to do is to always have their back supported, have them leaning back at about 60 degrees or so when they're up in their high chair or when they're sitting, so that they can lean against the back of the chair rather than doing the slouching thing, and hold off on that until they're able to get to the sitting position by themselves. This is from the literature. It's a 5-year-old girl with a 78 degree curve. You can see that huge kyphosis she's got at the very top over here. Well, what about treatment options? It can be difficult to draw conclusions because there are few cases in the literature to draw upon. So most of what I'm going to be talking about are really my opinions, which are based on accumulated experience, and gradually we're getting this into the literature as well. But the first thing is screening. Screening, I think, is extremely important. I'd want to wait until they are sitting before I start getting screening x-rays, except if it's a very clear case that the child's got a curve. And every now and then we'll see that even in the very, very young child, they've obviously got a curve. We get an x-ray of them laying down where we see we have to do something for them. But otherwise, I'll wait until they're starting to sit on their own, so gravity is going through the spine. Physical therapy, again, like we talked about before, so important to try to strengthen up the back. And then if we have a big enough curve, when it's over 25 degrees, that's when we'll start casting. Now, typically, I look to start casting before a child is 3 years of age, but I've actually started as late as 5 years of age. And then for the older child, or the child who's not appropriate for casting, then we'll look to do bracing instead. Now, the difference between casting and bracing is that casting can make a curve smaller, whereas bracing can only stop a curve from getting bigger. And then surgery for curves that are bigger than, say, 45 degrees is a rule of thumb. So physical therapy, we want to work on trunk strengthening, sensory integration. Some of the physical therapists talk about keeping the child down as long as possible so that they start using their arms for crawling. I'm kind of a split mind with that. I also want to get them up walking so that walking becomes a self-rewarding task in itself once they're ready for that. The important thing is that children with Prader-Willi syndrome develop their extremity strengths, their arms and legs, before they develop their trunk, which is actually the flip of typical children. Janice Agarwal, who I like to give this talk with, she says this is her favorite form of therapy, is horseback riding. And the reason for that is that you need to be moving your head, your trunks, your legs as the horse is moving. And that is not only an activity that the children really like, but it is also what they consider to be play activity, really working on strengthening. You have a therapist there to provide extra support, to maybe even create some resistance. Short of that, Janice likes to talk about soft proprioceptive orthotics. So kind of a suit that when you're moving, you can feel the suit moving against your skin, and that helps to give you an idea of where your muscles are moving in space and gives you a little bit more of an idea of balancing and coordination. And it allows the child to relearn proper motor patterns for functional movement. And these are things such as Theratogs, or the spine core brace. So quick reality check. It's important to say that even if you do everything right, there are going to be some curves that are going to continue to progress and that may require surgical treatment. And some of these curves are just very nasty in that way. And it's always an important thing to point out to parents that they'll go to the ends of the earth with their children and they'll still end up with a child who needs to have surgery. But the strategy is to control the curve as long as possible. So if they need surgery, that we get them as old as possible. So one of the things is casting. This is again for the young children. This is an early cast of mine. They look a whole lot better now. And the appropriate age has been changing. I used to say I'm only going to cast kids up to 3 years of age. Then we start realizing that actually it works pretty well. And the other thing is that the alternative, the surgical treatments that we have for the big curves, they have their drawbacks. And the big drawback is that you can only lengthen somebody's spine for so long before the spine starts to tighten itself up. It's about 5 years. So if you do an expandable type implant, which we'll be talking about in a little bit, if you do that at 3 years of age, by 8 years of age, you can't lengthen their back out anymore. Whereas if you do it at 5 years of age, you get them to 10 years of age. Or if you do it, wait until 7 years of age, maybe we get them to 12 years of age before their back gets too tight. So when we talk about casting, we have to do this under anesthesia. We change the cast every 2 months for children under 2 years of age. For children between 2 and 3 years of age, we change the cast every 3 months. And over 3 years of age, we just continue to change it at every 4 months. And we keep casting them either until we've reached our goal, which is making the curve small enough, or until we've reached a plateau where the curve is not responding anymore, and we think we should move on to a brace or maybe move on to some sort of surgery. Typically, we try to go for bracing. So this is a schematic of what the a casting table looks like. And what we're trying to do is not only push on the curve from side to side, but we're also trying to unrotate the curve. So you see that little inset picture over here. It shows what the chest does when you have a curve. The chest itself kind of rotates. This way you get the prominence in back. You also get a little rib prominence in front. And we're trying to take that and unspin that while we're correcting from side to side. This shows you a little bit more about how that spinning works. That as this child's curve goes off to the right side, the right ribs are getting pushed in back. So we want to try to push those right ribs forward to correct it out. So this is what our casting table looks like. It's called a Risser table. And what we do is we have head halter traction, and we have bands that cross to the pelvis that gives traction the opposite way. So we're kind of putting some traction across them. So here's the head halter traction. Here you can see these little strings going to the little pad underneath the chin there. And here's our traction bands at the pelvis. And there's a middle part of the table that then falls away. So the child is being supported by these two bars here, and we can wrap around them. And then once we wrap them, then we mold out the cast. We do some cutouts here, and we finish it up, and we have a nice finished product, and we're all done. So we looked at our cases of casting, and we were able to come up with 34 patients that had more than 2 years of follow-up. And our criteria for starting casting was that they had to be sitting age, but we didn't start them if they were over 5 years of age, and the curve had to be greater than 25 degrees. And we would cast them until we had a cured curve. So we had 3 outcomes. One is a cured curve, which is where the curve is small enough that we expect that it will not spontaneously progress for a while. So that tended to be a curve that was under 15 degrees, or that was less than 20 degrees for 3 consecutive casts. We put them in a brace for a year and then hopefully stop the brace after that. Then we would have the braced group, and this is the ones that we could not get down low enough that we could cure them, but we'd at least could transition them into a brace and watch them expectantly. And finally, there was the controlled ones. Those were the ones with the really big curves that all we were trying to do is temporize them until we had to go to surgery. So our results, average age that we started casting was about 32 months of age, but it varied between 14 months and 5 years of age. Number of casts on average was 8, and the average follow-up was about nearly 5 years. So we had 12 patients that were cured. 7 of these were UPD and 5 were deletion. And we start off with curves on average were 44 degrees, although we did have one child that had an 80-degree curve. That's him right there at 17 months. At 3.5 years of age, actually the curve was nicely corrected. I have to tell you though, that in his particular case, there we go, his particular case, the curve came back again. In fact, just recently he had surgery, but we were able to get him nearly 10 years out before we had to do any sort of surgery. But the end curve, when we finished all these children, was about 17 degrees on average. Took them 6 casts and about 18 months. And when we followed them up at about 4 years out, the average curve was only 20 degrees. So we actually did quite well with these children. We had 18 patients that ended up just graduating to a brace. So they went to a brace and stayed in a brace. 10 of these had deletions, 7 had UPD, and 1 had methylation defect. Now, what's interesting about that is that you remember in the cured group, it was more UPDs than deletion. Here it's more deletion than UPD, which suggests to me that UPD maybe has a slightly less concerning outlook as far as scoliosis goes. In this group, the initial curve was 55 degrees, and we could get it down to about 35 degrees with 7 casts over about 2 years of time. And when we followed them up, we found that the curve had slowly progressed up to about 47 degrees. So a number of these children will require surgery. And then we had the controlled group. These were ones that had very big curves from the start, and we were really trying to just help them, nurse them along for a while. So this first one here, she actually started off with a 54-degree curve, did a bunch of casting. She did well. Unfortunately, she could then not tolerate the casting because of breathing issues. And that's what that picture is on the right there, is when we saw her a number of months later, the curve had just gotten out of control and she required surgery. And these other 3 were really the same, except they start with much bigger curves in the range of 80 to 100 degrees. And after a long period of time of casting, we actually just transitioned right to surgery. So next, an explanatory case here. This boy's about a year and a half old, 32-degree curve. That's what it looked like after 4 casts. Here he is at 4 years of age, 2.5 years after we finished casting, looking pretty good. At 8 years of age, pretty good. But one of the things to say is that this is still very new treatment modalities in Prader-Willi syndrome. We don't know what happens as they continue to age. So in fact, here he is at 9 years of age. He has a 25-degree curve, and we started bracing him. And 3 years later, the curve's gone up to 32 degrees. So still doing quite well, but we have our concerns. Here, on the other hand, is a year-and-a-half-old girl. She started off with a curve that was more than 100 degrees, and we casted her for several years, 13 casts, 2.5 years, kept the curve in the 50s. And then we were able to move on to surgery because now she was just about 6 years of age and was a good age to do the surgery. So we could not find anything different between those curves that were cured and the other groups in terms of gender, what side the curve was to, or what kind of Prader-Willi they had. But we did find that if the curve was under 50 degrees, we had a 9 times better chance of curing the curve than if it was over 50 degrees. So, and I consider casting to be survivable. Here's a year-and-a-half-old boy, 55-degree curve. He had 5 casts over 15 months, and we braced him for 12 months. And now he's 7 years old and only has a 7-degree curve. So he's doing quite well. And here's some other casting pictures showing these children staying active. What about bracing? Well, bracing is for curves over 20 to 25 degrees. We want to use that to prevent progression. It can sometimes, it cannot usually make a curve smaller, but sometimes it actually does. So typically we don't think about making a curve smaller. We just think about it controlling a curve, such as in this child here who wore a brace for 4 years. The curve went up by about 12 degrees over that time, but we were still able to keep it in control. But then here's some of these cases that you see that really give you hope. This 5-year-old girl had a 46-degree curve. Here she is in her daytime brace, in her nighttime brace. And here she is at 9 years of age with a 21-degree curve. So we're very pleased about that. Now, this curve may progress still. She's still young, but she's doing pretty well. Here's a 10-year-old girl who had a 41-degree curve. Here she's in her daytime brace, nighttime brace. And here she is at 13. Her curve is only 25 degrees. And so looks like she's really headed for success. This young man had a very big kyphosis in his lower back. So his lumbar lordosis actually went over to kyphosis. And here we braced him. We've been bracing him now for about 4 years, and we've almost gotten his posture to be what would be normal. But on the other hand, here's a 10-year-old girl, had 30-degree curves, and we did what we normally do in terms of bracing, but her curves just got out of control, and we ended up having to do surgery for her. So what about surgery? Surgery is indicated for children who are going to have curves 40 to 50 degrees at maturity. We want to align the spine in the best possible position, not just in terms of the side-to-side curves, but more importantly from the front to back curves. and you want to hold that in position with hardware. There's a high complication rate for surgery in children with Prader-Willi syndrome, including infections, which oftentimes come from skin picking. There could be anesthetic issues, and so the anesthesiologist needs to understand Prader-Willi syndrome real well, as does the intensivist who's taking care of the child after they come out of the operating room. We can have hardware failure or bone pulling or hardware pulling out of bone because of the weak bone that they have, and so we need to plan around that. And I always like to say we need to educate fellow pediatric orthopedic surgeons to understand that this is a child with Prader-Willi syndrome who has scoliosis, not a child with scoliosis who has this other weird thing called Prader-Willi syndrome. So this is my first patient. Oh, sorry, this is not my patient. This is from the literature, 6-year-old boy with a 90-degree curve, and they fused this child. Now, the problem is the spine will no longer grow. So he's going to be an adult with a chest that's the size of a 6-year-old. So rather, this is my first patient, had a 100-degree curve at 6 years of age. And what we placed was an expandable implant. So we could gradually grow him up. And by the time he was 16 years of age, his curve was only 50 degrees. His chest was fairly symmetrical. And at that point, we graduated him. Now we have a much nicer way of doing this called the magic rods or magnetic expansion control rods. So these are a couple of rods you can put into the spine. And what you do is with an external magnet, you can lengthen out the spine. So you see here, this is right after we put the rods in. Here's a few years or a little while later where we can see these little blank spots happening within the rod here as the rod is expanding. And so instead of going to the operating room to expand them, we place this external magnet on them to expand them. What do we do at the end of this though? What can we do then? Well, here's a 10-year-old girl, 100-degree curve. We expanded her out, and when we got as far as we could, we just replaced her rods with solid rods because her spine had essentially fused itself down. And so we were done with her. Here's another graduate. At 11 years of age, we put the expandable rods in. At 14 years of age, we couldn't expand her any longer, put the solid rods in, and here she is 2 years later doing well. What about a spine fusion? Again, for curves that are going to be over 50 degrees when they're done growing, or for children who have a very big kyphosis that we need to treat. So this 15-year-old girl had a 67-degree scoliosis that we treated. 18-year-old boy with a large kyphosis, treated the same way. And what we do is we ground the vertebra with pedicle screws. Screws that go into the vertebral bones from back to front, and then we put the rods over them, and then we kind of scrape up the vertebrae so they think they've been injured. And what happens is they try to heal one vertebra to the next, to the next, to the next, and you end up with a solid bone. That solid bone can't bend anymore. But preoperatively, they need a workup. They have to have the pulmonologist see them to make sure that they are healthy for surgery, that they don't have any problems with sleep apnea. Anesthesia needs to see them and know that they're going to be difficult to intubate oftentimes, and that they may have some challenging IV access. In fact, most of these children, I'll put a central line into them because they need IV access for a prolonged period of time. We have to be worried about food sneaking behavior. And we tend to put these children in the intensive care unit after surgery. The high pain threshold oftentimes helps us because these children are easier to get out of bed the day after surgery, so we can get them up and walking around. They do have their problems with hypotonia, so we have to really assist them with their coughing. And the skin picking, it cannot be overemphasized. I again had another child who has scratched open his incisions just recently. And the problem is that they are just so quick, just a couple of seconds that you don't attend to them, and they will scratch at their back. The GI complications are a big issue. Their stomachs are very slow to wake up after surgery, and that tends to be the thing that keeps them in the hospital longest, is that they are hungry coming out of the operating room, but if you feed them, the food does not go down the pipe, and they just end up with a very distended stomach. Quick thing here, I know I'm out of time here, so I just want to talk a little bit about the position that children with Prader-Willi syndrome have that can be a real problem. And that's this kind of head forward position where they can end up getting kind of a junctional abnormality right at the top of where we do surgery. So when we look at the typical person, and we draw a line down from the top of their spine, it'll go just in front of the bottom of their spine at the very bottom. But children with Prader-Willi syndrome seem to be a little bit more balanced forward. They want to have their head more forward than the rest of their body. And we need to maintain that same position, because if we make them too straight, then they're going to try to create that bend themselves and either put a little bit of a deformity at the top of where the surgery ended or at the bottom here. So if you watch this area right there, this child keeps on bending that over further and further as they're trying to put their head where they're comfortable. And so this is a child that was sent to us for revision because they had created this huge curve up front here. So we actually it took a lot to straighten them out. Or this young man here, same issue, a very big curve at the bottom here that we had to straighten out. All right, last thing, growth hormone with scoliosis. I find growth hormone to be one of the most important developments for the treatment of children with Prader-Willi syndrome. I do not stop growth hormone around the time of either diagnosis of scoliosis or the treatment of scoliosis. There are some concerns that growth hormone, or there were some concerns that growth hormone would worsen scoliosis in children with Prader-Willi syndrome. That was actually based on another condition called Turner syndrome, where they did think that the growth hormone worsened the scoliosis. And actually, newer research throws doubt on that. And it seems like the growth hormone is actually only helpful. In the Prader-Willi syndrome survey, or the PWSA survey that was done in 2007, we actually found that every month delay in starting growth hormone increased the risk of needing surgery for a spine deformity by 0.7%. So my take on it is that the scoliosis is going to do what the scoliosis does, but having the growth hormone is just very important for keeping them strong and helping them to develop a good back in general. All right, sorry for rushing through the last part of that. That is my talk. And I am open for any questions if I can be of help.
Thank you so much, Dr. Van Bossie. That was all incredible information that, we all need to hear. So we appreciate it. But we do have quite a few questions, so we'll get to all that we can. The first one is, with the amount of time some of us spend on the go, should we worry about time in car seats when it comes to spine and scoliosis?
So not so much. Occasionally, some of the car seats need a little bit of a lumbar support, that they really allow the child to kind of sit very curved like that in the lower back. So I'll tell parents to take a small towel and roll it up and just put it at the very bottom of the back there to give them a little bit of a lumbar support, kind of giving them the small of the back in their car seat.
Thank you. The next one is it necessary to get fit with orthotics or flat feet, or is a good insole with arch support adequate for a teen or tween?
So for somebody who is done growing, by that time, there's nothing you can do to change the shape of the foot. So if they are comfortable with their foot, nothing needs to be done. If they have enough of a flat foot that they get tired in their foot by the end of the day, or they're not walking well, just a regular arch support would be a good place to start. If it really seems to be significant, then you can go to more of a molded brace. And I have the occasional child who has such a bad looking foot that we actually need to do regular surgery that we would do for a flat foot to straighten that out. But that's relatively uncommon that we have to do that.
Thank you. The next one is, our specialist has told me, and x-rays confirm, that our daughter, 3 years old, has a 12% curve. What can we be doing to improve this and avoid invasive procedures? And then what are the best practices around curve prevention for PT and others?
So for the PT and others, again, I'll just throw out a quick shout out for Hippotherapy. I think that's very helpful. But in general, just staying active. I typically like anti-gravity exercises. So things that you're working against gravity. I'll say swimming is a great activity, but it doesn't really work the back well in terms of gravity. So I want to do activities where they're running and jumping. And as much as we worry about trampolines and pediatric orthopedics, I think it's not a bad thing for children with Prader-Willi syndrome. But a 12-degree curve in a 3-year-old, I think you're actually starting to come out of the woods. We figure that we really have to worry until about 4 years of age. So if that curve has not progressed over 25 degrees by 4 years of age, you're probably doing well, and you don't have to worry until we get close to adolescence. But really, it's a matter of just keeping the child as active as possible. And probably also that'd be another good reason to make sure they're always sitting in a good seat that has something for lumbar support.
Thank you. The next question is, what would you recommend we seek, or would you, I'm sorry, recommend we seek out a provider to do the Schroth method of PT for mild scoliosis to prevent progression?
That's a tough one. The Schroth method takes a lot of concentration and dedication. And I also am not aware of much in terms of literature that says that it is very helpful for the typical child with scoliosis. And there's nothing talking about children with Prader-Willi syndrome with scoliosis doing the Schroth method. So from that standpoint, if your child will tolerate it and they can be cooperative, I don't think there's a downside to it as long as it's not a financial issue. But otherwise, I don't think it's the type of thing where I want people to really beat themselves up about if they can't get to doing the Schroth method.
Thank you. The next one is, my son had SMOs and he is walking around almost running now. So should I continue using SMOs? My son is 2 and was diagnosed with mild scoliosis. And then what can I do to correct it?
So if the feet look good when he's standing barefoot, the heels are not rolling terribly out to the side, the arch isn't flat to the ground, then I think you can stop using the SMOs. And what you would do then is try to spend a lot of time having your child walking on their toes, because that really helps strengthen up the arch and roll the heel underneath the ankle. And again, in terms of the child being diagnosed with some early scoliosis, the important thing is monitoring it and otherwise keeping them as active as possible.
Thank you. If a child has hip dysplasia, how long should you wait and monitor your child before considering surgery? What are some recommendations to improve hip dysplasia, and is hippotherapy recommended or not?
So I don't think hippotherapy will do much in terms of hip dysplasia because it doesn't do much around the hips. I'd rather go for, again, the running and jumping activities. I monitor these probably about once a year if I'm concerned about them, because I don't think changes are going to happen any faster than that. And really what I'm looking for is a year-to-year comparison. If I get to a point where there wasn't a whole lot of change from one year to the next, then it's time to do something. The only time to do something sooner is if it looks like the ball is really kind of starting to slip out of the socket, what's called subluxation. And if that's happening, like in the child I showed in my presentation, that would be a reason for doing surgery in a younger child.
Thank you. Do you find children with PWS's joints swell easily? It seems as though every time this woman's daughter falls onto her knees, they swell, but every time we get x-rays, there are no fractures. Could it be just the laxity of the joints?
I can't really say that I've been aware of a lot of swelling of joints in children with Prader-Willi syndrome, but certainly falling on your knees, you whack the joint that's between your kneecap and the bottom of your thigh bone. It's called the patellofemoral joint, and that can cause swelling within the knee. So that certainly could go along with that.
Thank you. And it looks like we have time for a couple more, so I'll get through these quick. Regarding baby equipment such as swings and bouncers, are they okay for infants? And then what about exercisers that have them in a standing position?
So in terms of anything that puts them in a standing position, again, I want to make sure that they are sitting on their own by that time, that they're able to get themselves to a sitting position, because then they've got the strength that if you put them in an exerciser like that, they're not going to slouch and maybe kickstart a scoliosis. Otherwise, in terms of all those other apparatuses, I'm fine with those. There's all these safety issues, of course, and I'm sure that as dedicated parents, everybody's going to look to make sure that Consumer Reports doesn't say they're on recall.
Thank you. What would you recommend to help my child who walks pigeon-toed?
You have to see the child to figure that one out. So yeah, that's a hard one to say. There'll be different reasons why that's happening.
Sure. And then maybe for one more here, does participation in swimming or aquatics or gymnastics help with core strengthening?
All those do. Certainly all those do. Yep.
Great. Well, we will do one more then. Nice quick one. When do you decide that a child has progressed out of a cast? So what degree do you feel comfortable moving back to bracing?
So when we're talking about the spines, If I can get that curve reliably under 20 degrees, when we take a cast off, we'll get an x-ray. If it's reliably under 20 degrees for 3 casts, or better than that, we get it under 15 degrees, that's when I will progress to bracing. And the idea that I'm expecting that's going to be a cured curve. So I expect I will brace them for about a year, and then hopefully I can stop bracing them, or maybe only brace them at nighttime.
All right, well, it is 4 on the dot, so we will, with that, just ask that anybody still around, if you can please take the survey after this session. You can also find it on the homepage of your virtual convention homepage. So we want to thank you so much, Dr. Van Bossie, again, for coming in today and giving us all this great information.
It was my huge pleasure. I can't wait to do it in person.
Thank you so much.
Enjoy the rest of the conference, everybody.